Good morning. I'm Imedex from The Ohio State University. I'll be discussing overview of the approach to marginal zone lymphoma. There are three subtypes of marginal zone lymphoma: MALT lymphoma, splenic marginal zone lymphoma, and nodal marginal zone lymphoma. The most common of these is MALT, which the most common location of MALT lymphoma is the gastric area, but orbital, cutaneous, GI, lung, and thyroid are also common areas of involvement. Marginal zone lymphoma is one of the subtypes of indolent lymphoma. There are several subtypes of indolent lymphoma as listed that are similar in appearance, and when making the diagnosis, it's important to distinguish between these as much as possible. While a lot of the therapies used are used in all these different indolent lymphomas, there is some differences in the response to those treatments or in the order that which you will preferentially give the treatments. And so it is important to distinguish the best you can which subtype you're dealing with. Treatment is, at least initially, a little bit variable. So as I mentioned, MALT, the most common location for MALT lymphoma is to have gastric MALT lymphoma. There is an association with marginal zone lymphomas in viral etiologies. So MALT has an association with H. pylori, and so patients who have gastric MALT need to be tested for H. pylori, as those patients who have H. pylori positive disease will often respond to antibiotic therapy only and require no further therapy. There is a caveat to this, and those are those patients who have a translocation 11-18. Even though these patients may be H. pylori positive, they rarely respond to antibiotic therapy or will frequently relapse if they do, and they often require radiation. Patients who are H. pylori negative should receive radiation. Other locations of MALT, these are often localized but can involve many areas. Radiation is the standard in most cases because of this localized disease. They may require systemic therapy if there are multiple lesions, as if there are multiple lesions within the lungs. Rituximab is often appropriate therapy if there are multiple lesions, as long as they are not significant in size. It's also a possible treatment for gastric or other locations where patients either decline radiation or it's contraindicated for any reason. While this often will resolve the area involved at the time, there is a risk of recurrence at other sites, including with orbital MALT recurrence on the contralateral side. Splenic marginal zone, these patients often have a more indolent disease. They present with splenomegaly. In addition to splenomegaly, they often will be able to detect a peripheral blood involvement by flow. Patients have bone marrow disease and will usually have some level of cytopenias. Splenic marginal zone has an association with hepatitis C, and in cases where this is positive, you can treat the hepatitis C with resolution of the marginal zone lymphoma at times. These patients can be observed until they're symptomatic, which often happens from progressive splenomegaly or cytopenias. They respond very well to single-agent rituximab therapy. In general, as a marginal zone is a fairly rare lymphoma, and a lot of the studies looking at how to treat nodal marginal zone lymphoma or progressive marginal zone of any of the subtypes are not done solely based in marginal zone lymphoma, but include several of the indolent lymphomas. So the STILL study was a randomized frontline trial that evaluated R-CHOP versus BR in indolent lymphoma. While the majority of patients were follicular histology, there was about 10 to 15% of patients with marginal zone lymphoma, which is pretty consistent across the studies when you look at the number of patients who are marginal zone. The STILL study showed that there was a progression-free survival benefit in the entire cohort of patients to using BR over R-CHOP. When you look at just those patients with marginal zone lymphoma, the median progression-free survival was not statistically significant, although that's likely because this is a smaller population and the study was not powered to show that. However, the median progression-free survival for BR was 57.2 months, with the median progression-free survival of the entire cohort of patients being 69.5 months. This established bendamustine rituximab as a frontline treatment for marginal zone lymphoma. Both bendamustine and rituximab and R-CHOP are appropriate frontline approaches. I prefer bendamustine rituximab based on the toxicity profile. Rituximab and lenalidomide has been evaluated in upfront marginal zone lymphoma. So this was a study, a small study, but 27 patients of just marginal zone lymphoma. As you can see, this included all subtypes, nodal, splenic, and extranodal marginal zone lymphoma. This showed rituximab lenalidomide to have very high overall response rates, including a 93% overall response rate with a 70% CR. Looking at the progression-free survival, the median progression-free survival was 59.8 months, so really comparable to what is seen with bendamustine rituximab. Again, this was a small population study. While this is not approved in the frontline setting, this is a reasonable option for treatment for frontline marginal zone lymphoma. Gadelin was a study that took indolent lymphoma patients at relapse and treated them with bendamustine versus bendamustine and obinutuzumab, followed by obinutuzumab maintenance. Again, in Gadelin, this included all indolent lymphomas, with follicular being the large population of patients. However, marginal zone did represent between 10 to 15% of the patients studied in this. Again, there was a progression-free survival benefit to the bendamustine and obinutuzumab, with further follow-up showing a overall survival benefit to using bendamustine in combination with obinutuzumab at relapse. So this established bendamustine and obinutuzumab as an option for relapse, especially in those patients who are not treated with obinutuzumab as frontline disease. Again, the population of marginal zone patients in this was low, and so it's hard to statistically say anything about the difference in that subset of population, but overall a benefit to the bendamustine obinutuzumab. And again, longer follow-up did show not just a progression-free survival benefit, but an overall survival benefit to this regimen. Ibrutinib is approved in relapsed marginal zone lymphoma. This was approved in 2017 based on a single-arm phase 2 study that included 63 patients with marginal zone lymphoma who had had one prior therapy. The overall response rate in this study was 48%, with almost all patients having a partial response to treatment. However, there were an additional 35% of patients who had stable disease and were able to do well on the ibrutinib for a long period of time. Looking at the response rate across the different subtypes of marginal zone lymphoma, this was pretty similar, 47% in MALT, 41% in nodal marginal zone, and 50% in splenic marginal zone lymphoma. The median duration of response in those patients who responded to treatment was actually not reached. With a median progression-free survival of about 15 months and a median overall survival not reached. This again was the first approved oral therapy in marginal zone lymphoma. Rituximab lenalidomide, I mentioned this, has been shown to be very effective in frontline in a small study. So the AUGMENT study was a study of rituximab lenalidomide in relapsed marginal zone and relapsed follicular. So the entire study included both marginal zone and follicular. It was not powered to necessarily look at the differences in each subgroup. Again, in this study, maybe a little bit higher, but about a little over 15% of the patients enrolled to this study were marginal zone lymphoma patients. that included all the subtypes of marginal zone. There was a significant difference when you looked at the entire cohort of patient in both the overall response rate and the complete response rate, with an overall response rate of 78% with rituximab lenalidomide as compared to rituximab alone, and a complete response rate of 60% versus 33%. When you looked at the response rate in marginal zone itself, there was not a significant difference, but again, this was not powered to show that. The entire cohort of patients, there was a progression-free survival benefit. So progression-free survival benefit in the combination arm, the median PFS was 39.4 months, as opposed to the rituximab alone arm, where the median PFS was 14.1 months. This translated into a 54% risk in progression or death with the combination of rituximab and lenalidomide. Overall, this was well tolerated. There was increased risk of infection and cutaneous reactions with the lenalidomide over that seen with rituximab alone. This established this regimen as a reasonable regimen to give also. The PI3 kinase inhibitors, so these are all approved. There's 3 different agents approved in relapsed follicular. All have been studied in indolent lymphoma, and all included patients with marginal zone lymphoma, with about the same 10 to 15% of patients included in these studies were marginal zone lymphoma. So idelalisib, this is a PI3K delta inhibitor. A single-arm phase 2 study was conducted in patients with indolent non-Hodgkin's lymphoma who were refractory to rituximab and chemotherapy. The primary endpoint of this study was overall response rate. And again, there were about close to 15% of these patients were marginal zone lymphoma. The overall response rate was 57%. And as you can see, the yellow line here is the marginal zone lymphoma patients. So the majority of patients with marginal zone lymphoma did respond to this therapy. Duvelisib, this is another PI3 kinase inhibitor. This was also evaluated in a single-arm phase 2 study in patients who were refractory to rituximab and either chemotherapy or radioimmunotherapy. The primary endpoint was overall response rate. In marginal zone, 14% of patients included were marginal zone, with a breakdown of all the different subtypes of marginal zone lymphoma. The overall response rate in this trial was 47.3%. The reddish maroon represents the patients with marginal zone lymphoma. And again, similar to the idelalisib, you can see that almost all patients with marginal zone lymphoma either achieve stable disease or a response to treatment. Copanlisib, so this is a third PI3 kinase inhibitor. Copanlisib is different than the other two in that it's an IV therapy given every 3 weeks until progression, whereas idelalisib and duvelisib are both oral therapy options. Copanlisib was also evaluated in a single-arm phase 2 study in indolent non-Hodgkin's lymphoma refractory to rituximab and an alkylator, or patients who had received 2 or more prior therapies. Again, 16% of the patients enrolled in this trial were marginal zone lymphoma, and the primary endpoint of this trial was also overall response to therapy. The overall response rate in this trial was 59%. If you look at the yellow, which would be the patients with marginal zone lymphoma, again, the large majority of patients, although numbers were small, but large majority had stable disease or a response to treatment. The PI3K kinase inhibitors do differ a little bit. Idelalisib tends to have a little more inflammatory and infectious toxicity associated with it. As I mentioned, the copanlisib as an IV therapy, whereas the idelalisib and duvelisib are both oral therapies. Lastly, I'm going to touch on chimeric antigen receptor T cells in non-Hodgkin's lymphoma and specifically marginal zone lymphoma. So we know that chimeric antigen T cell or CAR T therapy has significantly changed the way that we're able to treat refractory aggressive lymphomas with approval and relapsed diffuse large B-cell lymphoma for patients who are unable to get to transplant or progress after. So there is a lot of interest in the potential for, will this provide a potential for cure in patients with indolent non-Hodgkin's lymphoma? We know that outside of an allogeneic transplant, that indolent lymphomas are not cured. While the majority of patients will do well with the treatments that are available, there are patients who are refractory to treatment or progress quickly afterwards and can represent a difficult to treat population. So this was results actually just very recently presented at the American Society of Clinical Oncology. So this was the ZUMA 5 study that looked at chimeric antigen receptor T cells in, again, indolent non-Hodgkin's lymphoma. This included both follicular and marginal zone lymphoma. There were a total of 96 patients enrolled, 16 of those who were marginal zone lymphoma. They did break down responses by overall cohort of patients and then patients with both the follicular and marginal zone. So as you can see, of the 16 patients in marginal zone lymphoma who were treated, there was an 81% overall response rate, with the majority of those responses, 75%, achieving a complete remission. When you look at the duration of response, at a median follow-up of 15.3 months, the median duration of response was 20.8% or 20.8 months. However, when you look at the follicular versus marginal zone in the 16 patients with marginal zone at a median follow-up of 11 months, the median duration of response was 10.6 months. Progression-free survival and overall survival. So at a median follow-up of 15.3 months, the median PFS was 23.5 months. When you look at the patients with marginal zone lymphoma, median progression-free survival was 11.8 months with a 12-month overall survival rate of 100%. There is toxicity associated with the CAR T, similar to that which is seen in the large cell trials. So concerns of both neurotoxicity and cytokine release syndrome, and then patients after CAR T, concerns with cytopenias and infectious risk. So in summary, marginal zone lymphoma, when you're diagnosing this, it's important to differentiate from other indolent lymphomas, as treatment can be somewhat variable. There is an association with infection in both gastric MALT and splenic marginal zone lymphoma, and this is important to identify because treating those underlying infections, including H. pylori or hepatitis C, can at times resolve the lymphoma without lymphoma-directed therapy. Marginal zone lymphoma is a rare lymphoma, and there are few trials dedicated to it, and the ones that are small in number. Treatment is largely based on studies looking at treatment in all indolent lymphomas, and while it's not as clear in some of the randomized trials that there's a significant benefit to different treatments in marginal zone lymphoma, there's certainly small numbers that are not powered to show that. And so I think that looking at the overall outcomes of that population is still appropriate. I think that frontline bendamustine rituximab for patients who have nodal marginal zone lymphoma is largely the primary therapy used. Ibrutinib is effective in relapsed disease, which is one way this differs than follicular lymphoma. This is an area where follicular lymphoma, ibrutinib does not have as much activity, and the ibrutinib study in marginal zone lymphoma, this is the only oral approved agent with FDA approval in marginal zone lymphoma. Chimeric antigen receptor T cell therapy is new and exciting and may offer a potential cure for these patients. However, there is the the current outcomes maybe are not quite as good as one would have maybe hoped for in marginal zone lymphoma, especially given potential toxicity. However, I think longer follow-up and more patients treated are needed to really tell us the role of this therapy. And in those patients with refractory marginal zone lymphoma that's difficult to treat, this data may offer a good potential treatment option. Thank you.